You're listening to The Scoop on Ultrasound, where the world of ultrasound imaging comes alive through dynamic conversations. This episode is brought to you by EDM Medical Solutions.
In this episode, we dive into the future of cardiac imaging with Dr. Jordan Strom, a leading expert in echocardiography. As an associate professor at Harvard Medical School and director of echocardiography and imaging research at Beth Israel Deaconess Medical Center, Dr. Strom's work focuses on how cardiac structure and function impact health outcomes. With 100-plus peer-reviewed publications and leadership roles in the American Society of Echocardiography and International Contrast Ultrasound Society, he shares how cutting-edge research and technology are shaping the next era of cardiac care. Quality supplies make a difference. At EDM, our mission is to help you enhance patient care. For over 30 years, we have been a leading supplier of medical imaging products and accessories. It all started with one product, Crystal Ultrasound Gel. And now our catalog includes over 300 products designed to support your practice. From probe covers to needle guides, EDM Medical Solutions is the partner of choice for over 2,000 healthcare facilities in the U.S. Learn about our range of ultrasound solutions on our website by visiting us.edm-imaging.com.
Heart disease remains the leading cause of death worldwide, but the tools we use to understand and treat it have never been more advanced. Innovations in echocardiography are not only saving lives, but also changing the way we think about heart health. In this episode, we're exploring how cutting-edge research and technology are shaping the future of cardiac care. Today, we are joined by a leader and expert in the field of echocardiography, Dr. Jordan Strom. Dr. Strom serves as Associate Professor of Medicine at Harvard Medical School and holds several esteemed positions at Beth Israel Deaconess Medical Center in Boston, including Director of the Echocardiography Laboratory, Director of Echocardiographic Research, and Section Head for Cardiovascular Imaging Research at the Richard A. and Susan F. Smith Center for Outcomes Research in Cardiology. Dr. Strom's groundbreaking research focuses on the relationship between cardiac structure and function and its impact on health outcomes. He is also deeply committed to optimizing the use and timing of cardiac imaging in clinical practice. With over 100 peer-reviewed publications and editorial roles at leading journals like the Journal of the American Society of Echocardiography and the Journal of Cardiovascular Magnetic Resonance, Dr. Strom plays an incredibly active role in the field of cardiac imaging. His leadership extends beyond research and clinical practice. Dr. Strom has served on the board of directors for the International Contrast Ultrasound Society, as well as the American Society of Echocardiography, where he was the first ASE Leadership Academy member to join the board. Additionally, he is a co-chair of the Scientific Sessions Abstract Committee and chair of the Image Guide Echo Registry Committee, both of the ASE. He is, of course, a dedicated advocate for sonography education, representing the American College of Cardiology on multiple accrediting boards, including the Joint Review Committee on Education in Diagnostic Medical Sonography and CAHEP, the largest allied health accreditor in the U.S. He was formerly on the ACC Cardiovascular Imaging Leadership Council as well. Dr. Strom's expertise and dedication have made him a sought-after thought leader in echocardiography and cardiovascular imaging, so it's an honor to have him with us today to share his insights and expertise on the Scoop on Ultrasound. Dr. Strom, thank you for joining us.
Thank you so much for having me. It's a true honor and a pleasure to be here.
So let's jump in. Echocardiography has really revolutionized how we understand the interplay between cardiac structure and function. Studies such as those focusing on strain imaging and diastolic dysfunction highlight its potential to predict outcomes in heart failure. So, Dr. Strom, how is echocardiographic research really shaping patient outcomes and clinical practices?
Yeah, thank you. It's a really good and important question. And I think just to step back a bit, I want to reflect on how often echocardiography is performed in this country. And we estimate probably about 6 to 8 million individuals get echocardiography in a given year. And that is about 25% of all Medicare beneficiaries receive an echo in a given year. So it's a massive number of individuals. And so it's really oftentimes the first screening test for a lot of different diseases. Um, and it's sometimes the first time that people have any kind of interface with a cardiologist or sonographers through their experience with the echo lab. And so we really have a front-facing position, and that allows us to really be able to really take a central role in the public health of individuals who are out in the general population. And so what we find has large implications for how people are ultimately treated. And I often talk to my fellows about echo being the best biomarker of the heart, and that it really helps us understand more so than perhaps a single value or lab value or otherwise. It really helps us understand what's happening to the heart in a sort of very granular kind of way, and we can use that to make predictions. Now, a lot of echo thus far has been focused on how do we improve our diagnostic techniques? How do we get better at diagnosing people with certain diseases? How do we optimize our techniques for identifying those diseases and get them to an appropriate place? My sort of interest is really now what we've acquired all this data, and we have mountains of echo report data as well as images from these studies that have been done. How do we better leverage these data to really understand what works and what doesn't work, and what strategies work and are best for the patients that we treat? We hear from people that imaging is overutilized around the country. I think it's a complicated area where underutilization is often harder to measure than overutilization. The true sort of value or benefit that you get from imaging is hard to sort of parse out from the kind of treatments and the response to that. Yet, I think we have an opportunity to really be able to understand precision medicine in a much better fashion when we integrate people's imaging information to their clinical information and their outcomes to be able to get a fuller picture of their clinical care and their outcomes.
Right. So it truly is personalized attention, so to speak, right? That's the goal.
That's
You
right.
know, yeah, you leveraging that data in that way. It's amazing. Now, from 3D echocardiography to contrast enhanced ultrasound, you have a lot of advancements in technology, especially in recent years. Of course, we have everything going on with AI. And so it's fascinating to see how cardiovascular magnetic resonance and other techniques are being integrated into practice. Now, from your perspective, of course, considering your involvement in research and clinical practice, what do you see as the most impactful innovations in improving diagnostic accuracy and patient care? What role do imaging innovations play in modern cardiology?
Well, I'm a little biased in that, from the outset, we use probably about 30 to 40% contrast in our lab. And we're very strong advocates of contrast. I sit on the International Contrast Ultrasound Society board. I do feel that contrast is a very central piece of the equation, and underutilized one. We know that about 6.8% of all outpatient echoes receive contrast, and about 10 to 20% are suboptimal. That is, they potentially could have a need for them. So there's a deficit there, and I think that differs based on where you are in the country. If you walk into a hospital in Delaware, you have a 1% chance of getting contrast, versus walking into the same person walking into a hospital in Minnesota, where it's about 30 to 40%. So there's a real discrepancies in terms of our use of these agents. But I think as we expand down the road, there are lots of potential applications for so-called theranostics, where your microbubbles, these contrast agents, not only can be used to identify structures in the heart, but also be complex to certain drugs or antibodies that allow us to really do targeted molecular imaging and also deliver therapeutics in a targeted fashion to sites that need them. And we're going to need people in the Echo Lab who understand how best to utilize these so that we can study them and understand their effects on patient care. Of course, I would be remiss if I didn't talk about AI. I think a lot of my work and others has been around AI, and I think AI has come as a revolution for many fields, but no no less for for the medical technology and imaging space, and part of it depends on the input data. Um, like we've taken claims data um, and run it through complicated machine learning algorithms, and sometimes you get a a response that's no better than a simple statistical model. And it's why is that the case? Well, somebody's diabetes is not a one or a zero. It's a nuanced phenomenon, and there are sort of these gray areas that get missed when we ultimately try to make the data sort of fit our platform and make it easier to analyze. And we sometimes we miss out on that sort of, particularly if there's sort of these what we would call nonlinear associations with the outcome. We assume that there's a linear association between things like high blood pressure, diabetes, and somebody having an outcome. But in fact, there's lots of intricacies to that. The AI really tends to capture that. So if you take things like audio or visual things, particularly video clips like that we have with Echo, and run them into these convolutional neural networks, these deep learning algorithms, they can be really, really good at classifying disease. And I think so. There's lots of potential, and there's lots of people who are interested in trying to identify where that potential is and how we can better utilize it. Where we really have the big sticking points at this point in time, and where we really sort of the rubber hits the road, is we can develop these pieces of software, but how do they work in clinical practice? And what is rolling them out into the clinic do to people's ordering practices, to people's decision making, to their confidence in that decision making, and ultimately downstream to patient outcomes? And that part of that prospective piece of sort of using this is just starting at this point in time. And that's where we really see the field headed in where we really need to test which ones work, which ones don't, and how do we best make sure we're making the sort of the best effect. So that's part of it. And then we are also trying to create other methods to be able to validate and verify algorithms. There's lots of an interest in AI, but um, if it only works on people that show up at your medical center, but no other medical center, then it's not as generalizable. And so we want to make sure that it generalizes to the findings generalized to the patients we treat. And that's true across races, across ethnicities and genders, et cetera. So we want to make sure that we're not introducing biases by rolling out AI tools into care. And so there's a lot of testing that's needed, and there's a lot of data sharing that's needed. And, the one thing that we can really help to make our tools more generalizable is to have data that reflects the kind of patients we treat, and have generalizable data across vendors, across groups, et cetera, and make it easy to share that data so that we can learn from it, train it, and test the ability of our algorithms to perform accordingly.
Exactly. I really like how you mentioned that there's a need for testing right before rolling these out. And there's a lot of factors that have to be taken into consideration because sometimes people say, oh, we're going too slow or we're going too fast. And there's sort of a healthy caution, right? That other guests on the show have mentioned that has to be taken into account, that has physicians have to have and clinicians have to have when it comes to rolling out new things like this. And there's certain biases that, yes, can be introduced. And so the data is so important. Are we there yet? Maybe not right now, but we're getting there, right? Slowly but surely. But there's a certain caution that we have to have. Now, going back to what you were talking about of the contrast enhanced ultrasound, I'd love if you could tell the audience a little bit of the reasons behind the disparity you mentioned, because you mentioned how in one state, one patient may have a contrast agent used, but the chances in another state are a lot higher. So could you tell us some of the reasons you believe that those disparities are still there in terms of the adoption and use of some of these technologies?
Yeah, and I should say that disparity is still there when we account for things like age and clinical conditions and things like that
Mm.
that make somebody more likely or less likely to get contrast. We know even adjusting for those disparities, even adjusting for the rates of suboptimal image quality, we know that, for example, females get contrast at a lower rate than males do. Why that is, we've seen it is unclear. We've seen it in a number of different studies. It may have to do with sort of the less intense sort of treatment of females that we see across the board across the medical spectrum when we look at a variety of different sort of diagnostics and disease states. Um, but I think the biggest barriers are really those that are procedural, that are workflow related. Um, it's not hard to give a contrast agent, but you need to place an IV, and you need to be able to be trained on a contrast agent to give that contrast agent. And right now, um, less than 8% of sonographer institutions around the country offer any kind of IV training or certification. And you compare that to MRI or CT technologists, when they leave training, all get IV training. And so there's a real deficit. And so when it comes time to it, if you are doing an echo and you don't have IV training, but an outpatient walks in, they need contrast, and you have to call for an IV nurse to come place the IV, or you have to come wait to have somebody place this, sometimes 30-40 minutes before they finally arrive. And then you have 20 minutes left in your exam to do everything else in the rest of the exam. So it in many times, it just is simply people forego the contrast. And why there's a difference across um, areas is a little unclear. And part of it may have to be with people trained. Historically, Minnesota and Mayo and the areas around it have been really sort of strong when it comes to contrast and using a lot of contrast. And so people trained there may tend to stay there and follow those practices. But it really is a little bit unclear. There are certain things, for example, around the IV and also the contrast training that could be improved. For example, we know that not only is IV training deficient in many sonographer schools, but contrast training overall is very deficient. And when you ask people in the field, why is it that you don't use contrast more? The most common reason is that people don't feel comfortable because they haven't been trained on this. And so if you have educators who aren't trained, they can't train the next generation. The next generation doesn't learn it, and it's a cycle. So we're trying to break that. The International Contrast Ultrasound Society, as well as ASE, has a number of different resources online that are free and available for people to review about how to build a contrast lab, how to understand the safety and efficacy of contrast, et cetera, et cetera. And those are really powerful resources. We're also actively working with Intelios, which is the organization that runs ARDMS, to be able to create a certification around IV training, something that people can get after they leave school, so they don't necessarily have to have gotten it in school, but is something that will be a notch in your cap that you can bring to your institution. Say, I have had a national, international training on IV certification. I have a certificate. Is part of my overall credentials. And as we move as a field to, I think, acknowledge, rightfully so, sonographers for all of the work that they do, that's not just scanning, but outside of scanning, things like leadership positions and otherwise, IV training is another sort of feather in your cap you can bring to institutions. And a lot of institutions are now, ours included, are now actually have some compensation payment that's associated with those kinds of softer skill sets.
That makes so much sense. I mean, that explains, right, a certain part of the disparity, right? That deficit in education.
Yeah.
But it's really great to see that organizations such as the one you're a part of are already seeking to address that gap. And then we hope, of course, that healthcare facilities such as yours, more of them, will also compensate for those skills, because it's true. There's so many other things than just scanning, right? And that's so important to promote that and create that awareness behind it. Going on to that topic of education, proper education and accreditation, we know, are critical in ensuring consistency, quality, and practice. And we recently had Therese Cooper on the show. She's the chief learning officer of the AIUM, and she herself emphasized the importance of setting standards, right, to ensure better patient outcomes, to make sure we're all on the same page as a healthcare community. And so, could you elaborate a little more on your work in sonography education and accreditation, and perhaps also what you think the big issues are? I know you already were just mentioning one, but what other big challenges or roadblocks you've seen?
Yeah, really, really good question. So parse out what I do within sonography education. So there's not only sort of directing our own sonographers and our own lab and sort of taking on students and sonography students and training them on clinical sites. I also serve as medical director for the Mass College of Pharmacy and Health Sciences ECHO training program. And there I sort of have a lens into the training program overall on an individual site basis. And then through the JRCDMS, which really credits sonography schools across the country, I have an opportunity to sort of witness the larger sort of umbrella of sonography education. And I will say, it's not all created equal. There are sonography schools that do really, really well by in providing that education, and there's some that struggle a little bit more. And I think the biggest deficit in many ways is at limiting the number of programs is really the ability to have sort of clinical sites that are robust and allow people. And sometimes people have to travel quite a bit for clinical sites, or to have the diversity of clinical experiences that you can get as part of a clinical site. Can be challenging to get. And so, you can learn in a classroom, but it's very different than actually getting in front of a patient and doing a scan. And that's really where, I think the really good programs have both a robust sort of training pipeline, but also have some of the didactic aspects built in as well. It's key to be able to support our sonographers, and I think it's key to be able to attract people into the field of sonography. We know that in general, 70% of institutions around the country have sonographer shortages. That's actually that's in the most recent ASE trend survey. That is actually up from about a year ago, and has been steadily increasing since the pandemic. So while lots of other things have improved since the pandemic, sonographers have left the field in droves and continue to leave the field. And I think we have a real crisis of staffing, in that we can't provide the kind of care that we want to for patients and get them the ease of access to echoes if we don't have we don't make sonography a priority. And so I think part of this is recognizing the complementary role that sonographers provide to the profession, and that they are colleagues of ours and co-equals. And it's not a sort of an us versus them and not a hierarchy.
Right.
Part of it is improving the base standard of sonography education. And part of it is outreach to high school students and others who are considering and what you're doing right now, reaching out to people who might be considering a field in health profession. Say, this is a great field, and it offers a lot of patient facing contact. It allows you to be able to really be instrumental in people's lives, and it's one that has a professional development route that you can ultimately grow into. And so the more people who hear about it and know about it as an option, the more people are ultimately going to be, and talented people who are going to be going into the field of sonography. And that, I think, has promise in the future.
If you are high-level disinfecting your ultrasound transducer, it's likely you're soaking the probe or using an automated HLD device. But there's a better option out there. TriStel Olds can high-level disinfect your transducer in just 2 minutes and costs under $3 per cycle. Sound too good to be true? Request a brochure today and learn why so many practices are switching over to TriStel Olds. Visit us.edm-imaging.com/TriStel. That's TRISTEL. And now, back to the show. Yes, absolutely. And when you mention of inspiring the next generation to consider sonography, is very important. We've had a lot of guests who've mentioned that there's such a need. There really is a critical need for more sonographers. You have sonographers feeling burnt out who have left, unfortunately, especially after the pandemic. For those working particularly in hospitals, was a very difficult period. So you had a good amount which we lost, sadly. And you still have people who are feeling burnt out who are leaving. And we have such a need for more echocardiographers. And in other areas of sonography as well, other specialties are also experiencing a need. So truly very important to create more awareness. Now, moving back to the research aspect, which you're heavily involved in, it's no secret that research will often encounter hurdles in many ways. One of them being translating findings into clinical applications, but it also presents a lot of opportunities, right, to push the boundaries of patient care. That's one of the goals You have things like we talked to AI, machine learning algorithms, where there's a lot of research being done, and they've shown promise in detecting subtle abnormalities, things like that. And so there's so much going on in terms of the research world. But when it comes to your work, the research you've been doing, you've been involved in, what would you say are some of the challenges and opportunities you've encountered?
Yeah, it's another good question. In general, I think one of the challenges is always with researchers is funding. We live and die off of the funding, and for most of the people listening, you have a busy clinical practice. I mean, where do you find the time in your day to be able to fit in innovation? Even if you are seeing things personally on a personal basis, there's a better way to do this. It's sometimes hard to really carve out that dedicated time to really work on things to try to innovate. And um, to do that, you really require funding to be able to buy back, so to speak, part of your effort to be able to focus on research. And so a deficiency in funding is always an issue. And, we're thankful in this country. We have a great amount of supporters, both the NHOPI and American Heart Association, other foundations, et cetera, can support this type of work. But the more that we have and the more dedicated support we have, the better. Another is, just in general, is we have to be careful about the inferences that we make. People who get echoes are not the same as people who don't get echoes. There's a clinical decision that's made to refer somebody to echo that makes that person different from just somebody walking in off the street. And when we apply the results of those, we have to think about the how people were selected for inclusion in this study. So we try a lot to think about how do we generalize the results of these sort of real world data studies. And sometimes that's really challenging to do. Sometimes we have to accept even if we had 1 million echoes in a data set and a large robust sample we could look at, it may not be as good as looking at 100 or 1,000 curated echoes that are done purely for research purposes in terms of looking at the association between a certain finding and disease. So so there's challenges in the interpretation of the studies. There's challenges in funding them, and then I think of course there's always the day-to-day challenges in recruitment, retention, for large prospective studies. We want patients to sign up and be reactive in this. And to the extent that we have a lot of refusals, that can sometimes help, and it um, may not make our findings as generalizable to the kinds of patients we want to treat.
Right, right. Yeah, there's a lot of real challenges I'm sure present themselves, especially considering that so many times studies are multi-year, of course, and you have a lot of participants and you want them to stay on board. And it's a tough world, but it's such an important endeavor. It's definitely a very important endeavor. That's how we advance. Now, so often you really want to see a collaboration between academic research and clinical practice. So, what are your thoughts on that collaboration? How do you feel it can improve patient care in cardiology specifically to have a greater degree of collaboration between, the academia and the clinicians, academic research and clinical practice? How do you see bridging that gap? Do you feel that there's a gap, and how have you approached that yourself?
Yeah, it's a really interesting point, and there's some data on healthcare delivery sciences that even if, for example, the cure to HIV were a drop of water, that it would take several years before it was provided to the whole population. And a classic historical example of this is scurvy in lime juice for the treatment of scurvy. So scurvy is a collagen disease, and it's improved by vitamin C. Access to vitamin C, prevented by access to vitamin C. And so that's why the British sailors are called limeys, because they used to actually give limes to prevent the occurrence of scurvy with sort of long trips. But it took about 400 years before it was between when it was known about as a cure for scurvy before it actually got instituted in the British Navy. So just to say, the pace of science is rapid, but is far below but is far above the pace of development or adoption and care. And so we have some places that adopt and are early adopters, and some places that are slower adopters as well. And we really want to be able to translate that into patient care. One of the ways that I sort of feel strongly about this, Ati, is I see patients, I do echoes myself, I read cardiac MRIs myself, and a lot of the information or the questions that I have are generated from those kinds of encounters. And I'll give you an example of that. We published um, a score that identifies people's likelihood of needing contrast based on some of the characteristics they walk in when. The idea being that you can calculate it, you can identify who needs contrast ahead of time and have that person come in 15, 20 minutes ahead of time so they get their IV, and you're making the decision about giving the contrast based on their images, not based on whether they have an IV. Well, that originated from a conversation that I was having with one of our fellows at the time, who's now one of our faculty, who said, wouldn't it be nice if we can identify a better way to get contrast to people? So, well, we can do that. And so it's pairing that sort of analytical framework and saying what kind of questions are available, what kind of questions can we answer, and what kind of questions should we answer? And there's lots and lots of questions out there. Innumerable kind of questions. And we want to make sure we're focusing on the things that are the ones that are going to make the most impact for patient care. And so oftentimes we joke around in our research meetings. The question is, what's the question? Identifying the good question and the right question you can answer right up front that's actually going to make an impact is the hardest thing to do in research. And that's where having the clinical brain and thinking about the kind of challenges that you see in clinical care and connecting clinicians with researchers can really help to identify you have a problem, we have a solution, we can put them together and potentially have something that really can make a great deal of impact.
That's fantastic. I think that really gives insight into what an ideal world would look like. Hopefully, the world that we're working towards. I know you are and your team. So hopefully, that's where we're moving more and more towards is a greater collaboration, right? A greater, better questions, so to speak, better research, being focused on things that we really, really need, right?
Yeah.
As we close, I'd love to just get a few more thoughts from you about the future. There's so much going on there. I know a lot of people have a lot of predictions about what's going to happen in echocardiography and in cardiology, especially with what we talked about, all that technological innovation, hopefully greater adoption of new technologies. So for you, though, what do you envision as the future of echocardiography within cardiology? How do you see it being used and leveraged in the coming years, in the near future?
Yeah. Great question. If I had a complete crystal ball, I probably would, invest in the stock market a lot more or something of that sort. But yeah, different. But I mean, I can certainly give you my thoughts about where things are going based on the sort of trends that we're seeing within care. And I gave a lecture for the ACC's, the ACC at a conference where they talked about sort of future of echocardiography, and I talked on behalf of the ASE. I think, we're seeing a number of emerging trends in care. One is ultrasound's getting smaller. It's getting more, it's getting cheaper, and it's getting more democratized. That is, more people can get access to an ultrasound. When you can pick up a probe that costs $3,000, $4,000, that makes it a lot more versus $150,000. That makes it a lot more accessible to the public. And so I think we're going to have a lot of traditional ultrasound users out there who will do some involvement with ultrasound, or do scans, etc., or be involved in some way. And so I think we're going to need to understand a little bit better about how to ensure quality in that, and that what's picked up on or not picked up on is fully recognized. And then how do we integrate that into our existing framework of people doing echoes in a more traditional sense? And so the way I think that's going to happen is really more through a hub and spoke model, where the hospitals, big centers that are doing a lot of ultrasounds are going to be those hubs, and then there'll be lots of sort of spokes out in the community where people can get their ultrasound done as a screen. And if it's completely normal, the AI interprets it and says this is completely normal, then that affects their triage and perhaps maybe sort of if they need an appointment, if it's further down the road as opposed to something where you find something concerning and that person needs to come in more right away. And so I think that sort of on the ground at the point of care kind of triage is going to be a lot more frequent, particularly as some of the AI guidance software develops that helps people acquire adequate quality images despite being sort of relative novices in the field. And then as those big centers, I think we will see more pathology and less sort of normal studies as we sort of adapt to this framework. So I think AI is going to have a significant role in the development of that. And we just need to make sure that as a professional society and professional societies, plural, because we're not the only ones doing this within Echo, that we come to consensus about what point of care ultrasound is, because there's differences in terminology, but then also how do we best make sure the quality of the studies that are done is there and the quality of the reporting is there to make adequate quality clinical decisions. And ultimately, I do think that hopefully will improve access to ultrasounds to a large percentage of the population, which may not otherwise have access to be able to get them.
Yes, I mean, you make a great point with the greater use of ultrasound, right? As it becomes smaller, cheaper, and you even have now these AI guidance platforms and softwares that will help non-sonographers use it, right? Even if they're not interpreting the image, but to get more people to use it, truly is amazing and expands access. It really makes it a modality that is just so mobile. And I think over the coming years, like the consensus is that this is just going to grow. It's just going to grow.
And if I would just add to that, there's some basic questions that we don't have right now have knowledge of. And so I think this is not just going to have a role, on the clinical footprint. It's also going to have a role in research too. So I'll give you an example of that is, when I ask people, how many people in this country have severe valvular heart disease? And the answer is, we don't know, because we don't screen everybody in the country. And not everybody in the country gets an echo. And so there have been a number of really good studies that have extrapolated this from population-based studies where echo was done for research purposes, etc. But the answer is we really don't know. And where we do know for some of these things, like what's the rate of blood pressure, high blood pressure in this country, we know from, for example, community surveys like the NHANES study, which they have a mobile truck that goes around and surveys communities, and they have a population sample and extrapolate it to the overall population. Well, that kind of thing has not been so far possible to do with echoes, because there aren't sonographers who are sonographers are well paid. They're usually gainfully employed, and it's hard to get them to screen people as part of a sort of a large public health initiative. It costs too much. And so how do we do that? Well, now that ultrasound is less expensive and has guidance, and maybe we can incorporate that to be able to better understand even what the denominator of disease is, which I think at this point in time is still a big ongoing question.
That's amazing. I mean, that really magnifies the potential benefit of ultrasound, plus all the other ones that we've talked about. But that is incredible, just to be able to enhance preventative care in that way, reach more patients. Well, thank you so much again, Dr. Strom, for sharing your insights, your expertise. I really think that you provided our audience with a lot of value and a lot of great insight into what the future of echocardiography holds, and not just echo, but ultrasound in general, wherever it's being used, what the future could hold and what that could mean for sonography. Thank you.
Thank you very much.
Thank you for listening to this episode of The Scoop on Ultrasound. Subscribe today to be notified when new episodes are released, and visit our website, us.edm-imaging.com, to learn more about who we are and what we do.